Welcome to the Funnel Effect. Today we are conducting a deep dive into transcatheter edge-to-edge repair in secondary mitral regurgitation. It's based on a really critical state-of-the-art review that was published in Eurointervention in December 2025. The authors of this comprehensive material are Joseph Rodez-Cabau, Siddhartha Mengi, Erwan Salon, Jean-Michel Paradis, and William T. Abraham. So if you've been following interventional cardiology at all, you know that secondary mitral regurgitation, SMR, is one of the most stubborn and debilitating problems we face. It's not just common, it's frankly devastating. I mean, we are talking about the most prevalent valvular heart disorder out there. It strikes over half of all patients admitted with acute heart failure, and its impact is just severe. We're talking increased mortality, relentless hospital readmissions, what we call HFHs, and a profoundly diminished quality of life. Our mission today is to really cut through that complexity. We need to dissect the intricate pathophysiology of SMR, understand how the heart muscle fails the valve, and then tackle that central paradox of modern intervention. The conflicting results of the pivotal QAPT and MIND-TERRE FR trials. Ultimately, our goal is to uncover the precise critical parameters for patient selection that transform that's transcatheter edge-to-edge repair from just a promising tool into a true life-extending therapy.
And that transformation, that shift in status, is really the biggest news story in this field right now. Just a few years ago, TEER was, kind of reserved as a last resort option for patients deemed too high risk for surgery. Now, the overwhelming evidence, especially for these specific patient profiles, has catalyzed a major global guideline change. The updated 2025 ESC guidelines have elevated TEER for symptomatic SMR to a Class I recommendation level of evidence A.
Wow. Class I, level A.
Exactly. That is the highest possible endorsement. But, and here's the crucial caveat that dictates our entire discussion, this top-tier recommendation is strictly tailored. It's for carefully selected patients with ventricular SMR, and only after a guideline-directed medical therapy, or GDMT, has been rigorously and fully optimized.
Okay, so it's all about precision.
It's all about precision medicine. We've moved beyond just, fixing the leak. We're now defining who benefits, why they benefit, and maybe most importantly, when the intervention should actually take place.
Okay, let's unpack this enormous burden then. Heart failure globally is a catastrophic health issue. I think the number is something like 64 million people affected.
Over 64 million, yeah.
Right.
And it's the single largest cause of hospitalization worldwide.
So when SMR enters the picture, it seems to create this runaway train effect.
It truly creates a catastrophic feedback loop. To put it simply, SMR is the mechanical consequence of the left ventricle, the LV failing and dilating because of the underlying heart failure. So as the ventricle gets bigger, it pulls on the supporting structures, the papillary muscles and the chordae, and that prevents the mitral valve leaflets from closing properly.
They just can't meet in the middle anymore.
Exactly. And this functional failure, the regurgitation, imposes a massive chronic volume overload. Every time the LV contracts, blood squirts backward into the left atrium.
Which would drive up the pressure in the lungs.
Right. It elevates the LA pressure, intensifies pulmonary and systemic congestion, and makes all those heart failure symptoms, breathlessness, fatigue, edema, exponentially worse. It just accelerates the progression of the underlying disease.
So it's a vicious bidirectional relationship.
Completely. Heart failure causes the MR, and then the MR turns around and just hammers the heart, accelerating the heart failure and really reducing the patient's survival trajectory.
So what's immediately clear from the source material is that SMR is fundamentally a problem around the valve, not with the valve itself. The leaflets are fine structurally.
That's the key distinction. It's all about the geometry of the surrounding chambers. It arises purely from the adverse remodeling of the structures supporting the valve.
And we need to distinguish between the two primary drivers, ventricular SMR and atrial SMR.
Right. Let's start with ventricular SMR, or VSMR, because it accounts for the vast majority of cases. This is driven directly by that left ventricular dysfunction or dilation, the classic scenario we associate with severe cardiomyopathy.
Okay, but even within VSMR, there are different types, right?
Yes, and it splits into two critical structural patterns based on how the heart remodels. First, you have ischemic VSMR. This typically happens after a big regional event, like a heart attack, an MI. The localized scarring causes regional wall motion abnormalities and asymmetrical remodeling. So it's only pulling on one side, leading to this really uneven asymmetrical leaflet tethering.
Which must make it really tricky to repair.
It's a huge challenge for TEER, yeah. The whole game is catching those two leaflets that are moving differently. Then you have non-ischemic VSMR. This comes from global LV remodeling, often from idiopathic dilated cardiomyopathy or maybe long-standing hypertension. Here, the LV dilation is uniform, which leads to symmetrical tethering of both papillary muscles, and you get a nice central regurgitant jet.
So anatomically simpler, but the underlying muscle disease is probably more globally advanced.
Precisely. The geometry of the leak tells you a lot about the cause of the heart failure itself.
Okay, now let's look at the other subset, which seems to be getting a lot more attention. Atrial SMR, or ASMR. This seems like the most complicated form to manage right now.
ASMR is a major area of research, you're right, particularly as it relates to heart failure with preserved ejection fraction, or HFpEF. ASMR is characterized by this massive left atrial enlargement and isolated mitral annular dilation. It's often triggered by long-standing atrial fibrillation AF, which drives that adverse LA remodeling.
And the key thing here is that the LV can look fine, right? The ejection fraction is preserved.
That's what makes it so tricky. The LVEF is often preserved or near normal, so the LV muscle looks strong, but the chamber above it is completely disrupting the valve's function.
I recall the source material noting that even ASMR is highly heterogeneous, so this isn't just the valve ring getting wider.
No, it's more complex, and this nuance is critical for predicting outcomes. They distinguish between isolated mitral annular dilation, that's ASMR-IAD,
Right.
and the more aggressive form, which is called atriogenic hamstringing, or ASMR-AH.
Atriogenic hamstringing, what does that mean?
It's a great term. In ASMR-IAD, the annulus just expands uniformly. But in ASMR-AH, the advanced fibrotic LA remodeling causes this complex tethering. The atrium itself is actively pulling on the leaflets and chordae, restricting their motion. It's hamstringing the valve.
Okay, so if the atrium is actively pulling the valve apart in ASMR-AH, that must explain why the source material reports worse outcomes after TEER for this subtype.
It does. The durability of the repair is just less certain when the primary mechanism is that complex, aggressive atrial pull. This really underlines why our current studies still struggle to draw definitive conclusions about these pure ASMR populations. There's just so much heterogeneity.
All right, let's use the LVEF spectrum, the standard framework for classifying heart failure, to map this out. Where do these different types of SMR live?
Okay, so if we visualize that LVEF continuum, at the low end, you have HFrEF, heart failure, with reduced ejection fraction, so LVEF is less than 40%. This is the domain of VSMR. This is where you find the most advanced LV dysfunction. In the middle is HFMREF, the mid-range, with an LVEF between 40 and 49%. This is the complex overlap zone. Here, both ventricular and atrial mechanisms are often contributing equally, making it incredibly challenging to figure out the primary driver.
And at the high end, where the LV function looks good.
That's HFpEF, preserved ejection fraction, LVEF, of 50% or more. This is predominantly the ASMR population, driven by that LA enlargement and annular dilation.
So regardless of where the SMR starts, the natural progression, if you don't treat it, is pretty grim. Talk us through that vicious cycle and how it ends in biventricular failure.
The cycle is just relentlessly progressive, so impaired LV function and dilation drive LA enlargement. This, in turn, severely predisposes the patient to atrial fibrillation and, critically, secondary pulmonary hypertension.
The pressure backs up.
It backs up, and the sustained volume overload and hemodynamic stress just keep accelerating the adverse remodeling. This stress eventually extends beyond the left side of the heart as the high pressure in the pulmonary circuit starts to strain the right ventricle, the RV.
And that's the beginning of the end.
That's when things get really serious. It results in secondary tricuspid regurgitation and ultimately RV dysfunction. Clinicians use staging systems to track this, and stage 4 SMR is precisely this point, biventricular failure. And at that point, factors like severe pulmonary hypertension and RV dysfunction become potent, independent predictors of mortality. Our entire strategy for TEER is based on intervening well before the RV is irreversibly compromised.
Okay, so moving from the pathology to the pre-procedural phase, the starting point is always diagnosis. But it sounds like accurately quantifying SMR is like navigating a minefield because it's so dynamic.
It is extremely challenging. Echocardiography is fundamental, but it has major limitations in SMR. First, the severity is highly dependent on hemodynamic loading conditions.
Meaning it can change based on the patient's blood pressure or fluid status?
Exactly. If a patient is studied while they're resting or sedated for a transesophageal echocardiography, a T, their blood pressure drops, the heart fills differently, and the degree of MR will naturally lessen. This leads to an unreliable measurement that underestimates the true severity the patient experiences when they're symptomatic and walking around.
And the numbers we use to define severe are different too.
They are. For primary MR, severe is an EROA. That's the effective regurgitant orifice area of 0.40 centimeters squared or more. But in SMR, the thresholds associated with bad outcomes can be significantly lower, often an EROA of 0.30 centimeters squared or a regurgitant volume of 45 millimeters.
Why the lower threshold?
Because SMR often exists in low-flow states. The heart is weak, so the volume of blood passing back is smaller, even if the hole itself is severe enough to warrant an intervention.
And a major source of error is the PISA method itself. Why does PISA fail so often in SMR?
That's a crucial point for diagnostic accuracy. The PISA method, which calculates the regurgitant flow, assuming a hemisphere of flow acceleration, is prone to severe error in SMR. Because the regurgitant orifice in SMR, it's almost never a perfect hemisphere. It's usually elliptical or asymmetrical or has multiple jets.
So the math is based on a shape that isn't really there.
Exactly. If the clinician assumes a perfect hemisphere when the structure is actually elliptical, they can significantly underestimate the true severity. This dynamic complexity means we have to move beyond simple 2D measurements.
So what role does advanced imaging play in overcoming this, especially when you're planning a TEER procedure?
Multimodality imaging is indispensable. Three-dimensional or 3D echocardiography gives us superior accuracy because it can precisely define the true size and spatial localization of the orifice and the valve structure. For TEER planning, 3D color Doppler echo is critical for identifying the exact site of maximum regurgitation failure. That's where the clip needs to go.
And when echo isn't enough?
When standard measurements are inconclusive, cardiac magnetic resonance, or CMR, provides the most precise and definitive regurgitant volume measurements. It's flow-corrected and doesn't rely on those geometric assumptions. A meticulous pre-procedural assessment is just. It's absolutely necessary.
Okay, let's pivot to the intervention technology itself. TEER mimics the surgical Alfieri stitch, creating a double orifice. We have the widely adopted MitraClip and then the Pascal systems. Let's start with the evolution of the MitraClip from Abbott.
The MitraClip is the established technology, for sure. Over 200,000 procedures globally. Its evolution to the fourth-generation G4 system was a huge deal because it addressed the complexity of SMR anatomy. The G4 system introduced 4 distinct clip configurations, NT, XT, NTW, and XTW, which lets physicians tailor the device size to the patient's anatomy, accommodating more challenging cases.
And what was the most vital technical feature for dealing with those asymmetrical movements we talked about in SMR?
That would be the independent leaflet grasping. Remember how ischemic VSMR causes that asymmetrical tethering, making the leaflets move unevenly? Independent grasping lets the operator individually secure the anterior leaflet and then the posterior leaflet one at a time. This gives them far superior control and enhances the precision you need to secure those uneven, tethered leaflets. It dramatically boosted procedural success rates.
Then we have the Pascal system from Edwards Lifesciences. What differentiates its design, especially that central spacer?
Pascal uses a different architectural approach. It has these broad, contoured paddles and an integrated central spacer. The spacer is the unique selling point. When the leaflets are brought together, the spacer physically fills the remaining gap in the orifice, which helps ensure maximal MR reduction.
And it spreads the stress out.
It does. The broad paddles and the spacer also distribute mechanical stress across a larger area of the leaflet tissue, which might reduce the risk of localized leaflet trauma compared to just a simple pinch point clip.
And the newer Pascal ACE seems focused on overcoming anatomical constraints.
Exactly. The ACE is a lower profile version. It has slimmer paddles and a narrower spacer down to 2 millimeters from the original 5 millimeter. This increases maneuverability, which is vital when you're navigating challenging anatomies, and it helps minimize the risk of accidentally causing mitral stenosis after the procedure.
And we should point out that this overall TEER approach is broadly validated. The Pascal CLASP study showed some really impressive real-world outcomes.
It did. It confirmed the durability and efficacy of the TEER concept. The CLASP-PAC cohort showed 92% survival and 88% freedom from heart failure hospitalization at 1 year. It proved that TEER is a fundamentally viable and highly effective strategy.
Lastly, let's place this technology in its historical context. Why did we move from surgery and medical therapy to TEER?
Well, before TEER, the mainstays were optimized GDMT and cardiac resynchronization therapy, CRT. Surgery, while curative for primary MR, never showed a conclusive survival benefit for isolated SMR. Plus, the patients were inherently high-risk advanced age, severe LV dysfunction, tons of comorbidities. So surgery carried unacceptable risks. Patients who weren't surgical candidates were just left with medical management that often failed to stop the progression.
So TEER filled a massive gap.
A huge therapeutic gap. The rapid progression from the early Everest trials in 2003 to the 2025 Class I recommendation shows just how compelling the survival data specifically from the COEPIC trial proved to be. It gave us a way to offer mechanical relief without the trauma of open-heart surgery.
Okay, now we dive into the core lesson of SMR management, the conflict between the COEPT and mitral trials. This wasn't just a slight difference in outcomes, it was a fundamental disagreement on the survival benefit, and the answer seems to be all about patient selection.
This landscape changed everything. Let's revisit COEPT first. This is the trial that established TEER's prognostic benefit. They enrolled patients with severe but disproportionate SMR.
What does that mean, disproportionate?
Clinically, it meant the MR was very severe, mean EROA of 0.4 centimeters squared, but the heart wasn't irreversibly dilated yet. Their mean left ventricular end diastolic volume, the LVEDV, was 193 millirine. In this population, fixing the MR was like taking a massive destructive load off a struggling but still salvageable heart. The results were clear. A huge sustained reduction in mortality, a 38% relative reduction at 2 years, and a durable reduction in HF hospitalizations.
So for that group, the MR was the main problem driving their decline.
It was the primary driver, yes.
Now contrast that with MENGA-HER-FR, which was published at the same time and showed no survival benefit. The only real difference was the state of the heart muscle.
Correct. mitral-FR enrolled patients with proportionate SMR. So the severity of the MR was proportionate to the severity of the heart failure. The MR was actually less severe, mean ERA of 0.31, but the LV remodeling was profoundly advanced. Their mean LVEDV was 250 millimol.
Let's pause on those numbers for a second because they're crucial.
Yeah.
LVEDV, 193 LL in COAT versus 250 millil in mitral-FR. That 57 milliliter difference in volume seems to dictate life or death.
It does. Clinically, an LVEDV of 250 millil signifies a heart that is essentially a large, floppy, scarred bag.
It's beyond repair.
The muscle tissue is likely replaced by non-contractile fibrosis. In that scenario, the MR is just a secondary symptom of terminal myocardial failure. So fixing the MR with TEER helps with volume overload for a bit, but it doesn't solve the underlying problem. And that's why mitral-FR showed no significant benefit in mortality or HFHs.
And this led to the big disproportionate hypothesis. TEER only helps when the MR is way out of proportion to the LV dilation. If the LV is salvageable, fix the MR. If the LV is too big, the repair is futile for survival.
It's a compelling framework, but the source materials is quick to offer a critical critique. The hypothesis is unstable.
How so?
SMR is dynamic. A patient's classification can shift from disproportionate to proportionate, depending on their diuretic dose, their volume status, their loading conditions when they get the echo. You can't base a life or death decision on a potentially transient ratio.
So what's a better way to look at it?
The deeper insight is that the ratio is less important than the absolute metrics of irreversible damage. The new focus is now definitively on the size of the ventricle. Excessively large LV volumes, specifically an LVEDV over 200 to 220 milliliter, or an LV diameter over 65 to 70 millimeter are independent prognostic attenuators. They signal advanced disease, regardless of the ERA ratio.
Which brings us to the third major trial, ReShape-HF2. This one seems to confirm the symptom benefit, but not necessarily the survival gain outside that narrow COAPT window.
ReShape-HF2 enrolled an intermediate group, sitting right between the COAPT and mitral-FR extremes. Their MR was less severe, mean EROA of 0.25, and their LV volumes were intermediate, with a mean LVEDV of 205 millimera.
And the outcome reflected that middle ground position.
It did. The trial showed robust symptomatic success, a significant 41% reduction in HF hospitalizations, and a clinically meaningful improvement in quality of life. But, and this is the critical part, no statistically significant survival benefit was observed.
So the implication is clear.
Very clear. TEER is an exceptionally powerful tool for alleviating symptoms and reducing the crushing burden of hospitalizations. But that life-extending promise we saw in COAPT requires intervening at that specific, earlier anatomical stage before the LVEDV crosses that point of no return.
Okay, finally, let's talk about Matterhorn. The head-to-head trial of TEER versus surgery. This must have been crucial for cementing TEER's place in the guidelines.
Matterhorn provided the direct comparison the field absolutely needed. It randomized SMR patients to either TEER or surgical mitral valve intervention, and the finding was definitive. TEER achieved non-inferiority compared to surgery for the primary endpoint. While surgery gave a slightly better immediate NISAR reduction, TEER maintained good MUSAR control in 96% of patients and, significantly, had a superior safety profile.
Which is huge for this patient population.
It's huge. Since surgery already carried high risk and lacked clear survival benefit data for isolated SMR, Matterhorn justified the 2025 guidelines, making TEER the primary interventional choice for severe SMR in the right candidates.
Okay, moving beyond these controlled trials, real-world registries give us a crucial perspective. They often involve sicker, older patients who would never make it into a trial. How has TEER performed in these high-risk groups?
The registry data is generally very encouraging, especially because it reflects current best practices and newer devices. The COAPT post-approval study, or COAPPA, tracked over 5,000 SMR patients. These patients had more advanced heart failure and less optimized medical therapy than the original trial participants.
Yet they had comparable outcomes.
They did. Despite the higher risk profile, their one-year mortality rate was similar to the original trial's GDMT-only arm, and their HF hospitalization rates were actually lower.
So what does that tell us?
It suggests that the continuous improvements in TEER technique, the newer devices like the G4 and Pascal ACE, combined with greater clinical experience, have significantly elevated outcomes for this challenging group. And to reinforce the symptomatic benefit, the EXPAND study showed an extraordinary reduction in annualized HF hospitalization rates. They plunged from 108% pre-TEER.
So on average, more than one hospitalization per patient per year.
Exactly. Down to just 38% post-TEER. It just underscores the transformative potential of TEER in mitigating the massive clinical and economic burden of this disease.
Symptom relief and fewer hospitalizations are major wins. But what about the long-term prognosis? Does the mechanical fix last, and how does mortality look 5 years down the line?
Mechanically, the durability is impressive. The EuroSMR registry tracked a large high-risk cohort for 5 years. It showed that over 85% of patients maintained a stable, good reduction in their misseretion. The repair holds up.
However, the overall survival rate tells a more sobering story.
It does. The 5-year survival rate in the EuroSMR cohort was only 35%, which is significantly lower than the 42.7% they saw in the 5-year COAPT follow-up.
And why the difference?
It's perhaps the most important real-world lesson. While TEER effectively fixes the valve and relieves the hemodynamic stress, it does not cure the underlying progressive systemic heart failure that caused the SMR in the first place. The high mortality reflects the advanced stage of systemic disease in these real-world patients.
This means we absolutely must look beyond the LV and the valve. The source material emphasizes that extravalvular cardiac involvement is the critical determinant of long-term outcome. So what are the key predictors of mortality outside the left side of the heart?
When assessing risk, physicians are now laser-focused on the right side and the pulmonary circulation. The two major independent predictors of mortality in these patients are pulmonary hypertension and right ventricular, or RV, dysfunction.
How do you measure RV dysfunction?
We assess it using metrics like TPSE, tricuspid annular plane systolic excursion. It measures the longitudinal movement of the RV. If TPSE is low, it means RV failure is imminent and the patient's prognosis is poor. These findings really underline the value of sophisticated staging systems for SMR. The proposed 4-stage model stratifies patients based on this extramitral involvement. Stage 3 is RV pressure volume overload, and Stage 4 is full biventricular failure.
And the data shows mortality climbing at each stage.
It climbs steeply and significantly, and this is the anatomical rationale for early intervention. We have to act before the disease irreversibly compromises the right ventricle.
So moving into therapeutic strategy, the foundational message is crystal clear. Guideline-directed medical therapy must be optimized first. TEER is not a substitute for GDMT.
No, it's an enabler of it. That synergy is the key to prognostic success. Modern GDMT, especially the newer drugs like ARNIs and SGLT2 inhibitors, have fundamentally changed SMR management. They actively induce reverse cardiac remodeling. They shrink the LV and improve its function, which can itself reduce the severity of the SMR.
So why do we still need TEER?
Because many patients with severe SMR are too fragile. They're too hypotensive or too congested to tolerate the necessary high doses of these life-saving drugs.
So TEER buys them the stability they need to get the full medical dose.
Precisely. TEER alleviates the immediate volume overload, stabilizes the patient's hemodynamics, and creates a critical clinical window to then successfully uptitrate and intensify their GDMT. The EuroSMR registry showed this perfectly. GDMT uptitration happened in over a third of patients after TEER, and this was independently associated with lower mortality and HFH rates.
So the TEER solves the mechanical problem so the meds can solve the muscular one.
It's a perfect partnership, and this synergy even extends to mitigating the prognosis associated with RV impairment. Alleviating the severe MMR reduces the pressure transmitting backward to the lungs, which reduces the afterload on the RV.
Yeah.
It helps stabilize the right side of the heart.
Let's also talk about cardiac resynchronization therapy, or CRT. We know that 30 to 40% of patients who get a CRT device for heart failure don't see an improvement in their SMR. What about that group?
This is a critical indication. Patients with persistent severe SMR, despite adequate CRT, have a dismal prognosis. The mitral CRT trial specifically confirmed TEER's role here. It showed that TEER significantly reduced the composite endpoint of cardiac death, transplant, and HFH in these CRT non-responders. It cemented TEER as a necessary salvaging strategy for this very challenging cohort.
Okay, now we arrive at the central doctrine of success, patient selection. Given the wild differences in outcomes, the COAPT-like profile must be rigidly adhered to if we're aiming for that long-term survival benefit. What are the definitive criteria?
The COAPT-like profile is the gold standard, and physicians have to remember that a single exclusion criterion is enough to classify a patient as non-COAPT-like and dramatically lower the predicted survival gain.
So what are the key parameters?
Okay, we can summarize the key points that avoid those thresholds of irreversible damage. First, symptomatic status. NYHA Class 2B symptoms despite at least 30 days of optimized GDMT. Second, LVEF.
Yeah.
It has to be in the sweet spot of 20% to 50%.
And third, the LV size limits. This is the big one.
This is the most crucial measure, avoiding the MITRA-FR error. The LV must not be excessively dilated. We're talking a left ventricular end diastolic volume, LVEDV, of 220 millimeters or less, and a left ventricular end systolic diameter, LVESD, of 70 millimeters or less.
And what about those extrametral markers?
No severe pulmonary hypertension, so PA systolic pressure should be 70 or less, and no severe RV dysfunction, so TAPSE should be above 1.5 centimeters.
Beyond those systemic criteria, the anatomy has to be feasible for the procedure to last.
Favorable anatomy is paramount. We look for a coaptation length of more than 2 millimeters, enough leaflet tissue, and a mitral valve area of more than 4.0 centimeters squared after the procedure. Conversely, factors that highly predict poor outcomes, even if the repair is successful, include things like advanced remodeling, inducing mitral stenosis, chronic kidney disease, and of course, severe RV dysfunction. These systemic failures will just undermine the best mechanical repair.
Given the sheer number of interacting variables here, the source material argues strongly for moving beyond just clinical judgment and adopting advanced risk scoring systems.
This is where precision cardiology steps in. These scores integrate all these complex risk factors into algorithms that give us a much better prediction of one-year mortality compared to relying on generic surgical risk calculators. They help us filter out patients who are just too sick from systemic disease to derive a survival benefit.
What are some examples?
Well, there's the Mitra score and the Euro SMR score. The Mitra score is an 8-item algorithm that includes things like age, anemia, kidney function, LVEF. The Euro SMR score is even more sophisticated, often using AI to combine clinical, anatomical, and even GDMT adherence data to identify those extreme risk patients.
And the COAPT risk score is calibrated specifically for the outcome we care most about, 2-year mortality or HFH post-TEER.
Exactly. It uses factors like NR severity, renal function, and pulmonary pressures to give a highly personalized prediction of that COAPT outcome. These scores are essential tools, moving us away from simplistic anatomical criteria and toward a holistic assessment of the patient's overall systemic fragility.
So let's end by looking ahead. The evidence is solid for the COAPT-like profile, but where is research pushing the envelope for populations that are still underserved or traditionally deemed too sick?
Research is focusing on both ends of the spectrum. First, the incredibly sick population. TEER is a bridge for advanced HF patients who are waiting for a heart transplant. The Mitral Bridge Registry looked at this.
And what did they find?
It was stunning. They found TEER was feasible in these critically ill patients. But the big finding was that 23% of them improved so much that they were actually delisted from the transplant criteria.
Wow. So it wasn't just a bridge to transplant, it was bridge to recovery for some.
Exactly. A massive result. Then second, you have the ASMR population, which remains highly complex. The randomized camera pilot trial is underway to clarify the best strategy there. Should we focus on aggressive rhythm control for the AF or interventional repair of the SMR with TEER? That trial will address a huge area of uncertainty.
And finally, what about the most extreme risk cases?
That's the MINOS trial. This is a randomized study testing the safety and efficacy of TEER in the sickest of the sick patients with SMR who are in inotrope-dependent cardiogenic shock. If TEER can stabilize this cohort when drugs are failing, it would open a completely new pathway for acute, life-saving intervention.
All of this complex data, the conflict intervals, the rigid selection criteria, the evidence that the RV is key, it brings us back to the central problem of timing. We know TEER works best when the LV is not too severely remodeled, when LVEDV is under 220 mmol, and when it enables us to intensify GDMT. But delaying intervention often means facing those irreversible factors like RV dysfunction and severe pulmonary hypertension. So here's our final provocative thought for you, the listener. Should the medical community shift its focus entirely away from treating symptomatic late-stage SMR? Instead, should we be actively working to identify patients with moderate SMR who still meet those favorable anatomical and hemodynamic COAPT criteria and intervene early to prevent the irreversible progression to stage 4 biventricular failure? It moves the question from can we salvage this patient to can we prevent this patient from ever needing salvaging?
That is the essential question that will define the next decade of this field. We have the data to identify the tipping point. That moment, SMR transitions from being a consequence of HF to a primary driver of deterioration. Targeting that specific early window, supported by optimized GDMT, is where TEER offers the maximum prognostic benefit.
So, to synthesize the monumental shift we've covered, TEER's upgrade to a Class I recommendation is huge. But success is entirely dependent on adhering to these detailed selection criteria LVEF of 20-50%, limited LV dilation, favorable anatomy, all built upon a rigorous foundation of fully optimized guideline-directed medical therapy. Thank you for watching The Funnel Effect.